and welcome to the session on integration of palliative care in interstitial lung disease. Progressive fibrotic interstitial lung diseases are chronic diseases causing fibrosis of the lung interstitium. They are characterized by major effects on quality of life and survival and are similar to certain malignancies. However, most of the patients with ILD do not have access to palliative care services. To chair this session, we have two eminent members of faculty. I would like to introduce and welcome Dr. Ankit Bansal, Consultant in Pulmonology and Critical Care at Fortis Jaipur, and Dr. Sumita Mohanty, Associate Professor, Department of Onco and Sociology and Parent Palliative Care at Cuttack, Odisha. Over to you, Dr. Ankit.
A very good evening to all. At the outset, I would like to thank Indian Association of Palliative Care, Anju, for me in this prestigious conference and a very academic session on the palliative care on interstitial lung disease. As we know that interstitial lung disease is a very chronic entity, and many issues are there which needs to be addressed simultaneously. As a respiratory physician, I encounter these in my daily routine. So for this great academic session, first of all, I would like to invite our esteemed speaker, Dr. Miriam Johnson. Could you place his CV, please?
Yes, sir, we will. Thank you.
It's in the previous slides. You can't read it, right?
Dr. Miriam Johnson, he is presently the Professor of Palliative Medicine, Director, Wolfson Palliative Care Research Center. She is also affiliated to Hull York Medical School, University of Hull. She has a vast experience of more than 30 years, and her area of interest is palliative care in non-malignant disease, particularly breathlessness. So she has achieved a more than 20 pounds million grant income with more than 260 publications. So I invite her for her session on need of assessment of patients with ILD.
Hello, and thank you for the opportunity to talk with you today about needs assessment for people with interstitial lung disease. So we're going to cover something around, well, what's the problem anyway? And then start to think about, well, how can we tell who needs palliative care in interstitial lung disease? I'm going to go through a couple of key principles, then look in a bit more detail about some tools that might be able to help, including the needs assessment tool for interstitial lung disease, and then talk a little bit about how this might be implemented in practice and the sorts of issues to be aware of. So what's the problem? Well, it's because interstitial lung diseases have a very high symptom burden, and with the most prevalent form, a poor prognosis. There is also often poor communication and coordination of care, especially surrounding the end of life. And despite, at least in the UK, national guidelines, routine assessment of palliative care needs are rare. And back in 2015, only 3% in the UK access palliative care in a national registry report. And although things are improving in the UK, we still have a long way to go. And I suspect that is the same the world over. So what is the problem? Common persistent symptoms. So we published a systematic review looking at pooled prevalence of symptoms in papers published around symptoms in interstitial lung disease. And just to highlight some issues on the forest plot, so the middle line, 0.5, that is 50% of the patients in those papers were reported to have these particular symptoms. So here we go, breathlessness. If you look at the red diamond, you can see it's way over 50%, almost getting towards 100%, and the same for cough. If we look at gastrointestinal symptoms, we have significant proportions of patients suffering from significant gastrointestinal symptoms. If we look at sleepiness and fatigue, it's not quite as many as cough and breathlessness, but it's still a significant proportion of people with these symptoms. Weight loss, not so many, but it's a sign of serious and advanced disease and reported by a percentage of people. If we look at depression, here we go again, a significant proportion of people suffering from depression and also chest pain. So we can see these patients are symptomatic. So who needs palliative care? Well, the symptomatic need palliative care. Also, those likely to be progressive, even if relatively asymptomatic at presentation. And you have all been familiar with the patients, especially the respiratory people among you who may be listening, that you can often predict the person that is going to run into problems. They might be fine at the minute, but you know that that course is going to be a rocky road. These issues are challenging, so particular challengings. Those with non-IPF fibrosis who might stabilize, but also they may progress from the outset. So there is this degree of uncertainty if we think only about prognosis. Challengings, those who have been stable but are now deteriorating. And it's really easy to miss those patients because the stability almost lulls the clinicians into a false sense of security and the patients themselves. And then those with pulmonary function responding to treatment, they may be responding for now, but then how do we identify those who then start running into problems? Key principle, therefore, is that we need to have a needs-based approach to people with interstitial lung disease. Prognosis is relevant, and it's not to throw the baby out with the bathwater, as we might say. Spotting those for whom early palliative care is warranted is very useful, and giving patients and their families a ballpark of what they're facing to help them frame the important things that they want to do for their remaining days. But prognosis in terms of getting people access to palliative care is a big barrier in non-malignant disease, and interstitial lung disease is no different. If we're waiting for end of life, it's very hard to tell that. And so therefore, another way of flipping that is to say, well, what are the needs today? What are the problems that the patient and the families are having to address today? And if we do that throughout the disease course, we will pick up the people who are needing additional support. Needs-based care allows basic palliative care by the interstitial lung disease team and primary care, and it allows intermittent access to specialist palliative care when the needs dictate. And that is also an easier conversation for respiratory teams, for example, to say, look, you've got persistent breathlessness. I've tried this, that, and the other. I can see it's a problem. Now, in this circumstance, what we usually do is ask our palliative care colleagues to help us. And then once they've been able to help and things are a bit more better, you think you can manage things a little bit better, then they'll be able to discharge you. Rather than waiting so that palliative care referral is always, and we think you're going to die very quickly. Prognosis, I would therefore put to you, is a bit like the Holy Grail. If we wait until deterioration is incontrovertible, completely obvious, and irreversible, with no chance of stabilization or improvement, the patient will be dead, and you will have missed many opportunities to address serious issues in helping them live well until they die. Key principle 2. There are skills that all respiratory clinicians, and I would also say all primary care clinicians, looking after these patients need. We've seen the top 3 big lot of symptoms: cough, breathlessness, and gastrointestinal. They need to have all clinicians need to have basic skills to assess and manage these top 3. And I would put my neck on the line to say, I think this should be mandatory for every interstitial lung disease clinician. Need to have basic skills to identify and triage the concerns that are beyond their skills and need referral to other people who can help. And so therefore then also needs to be clinical pathways with specialist palliative care and primary care. These should be established so that that patient can have access to the particular care for the particular issue according to their need. So again, key principle 2. However, the flip side, specialist palliative care for all is unnecessary and unsustainable. Most of these issues and needs can be addressed by the usual care clinician, even if it needs a little bit of extra training and support to start with. So tools to help. I'm going to talk to you mainly about the needs assessment tool in progressive disease and ILD. So that's the NAT-PD ILD. I'll call it the NAT-ILD for short. There are other decision aid tools, so like the supportive care decision aid tool reported by the Bristol group. And there are other approaches also in the literature. So, for example, a team in Canada are doing great things with a multidisciplinary collaborative ILD clinic with a palliative care bundle. And I've put the references there that you can see. I'm going to talk about the needs assessment tool because it is only, well, firstly, because I was involved in that work, so it's one I know, but also the needs assessment tool is validated, and we do know the psychometric properties, whereas the SCDAT is a bespoke tool that has not been subjected to psychometric validation. I would also say that the needs assessment approach and other approaches are not mutually exclusive. So something like the needs assessment tool could be used as part of a palliative care bundle. So what is it? The needs assessment tool is a one-page, valid, reliable, and clinically acceptable tool for assessment of patients and caregivers' palliative care needs across a broad range of domains. It differentiates between the need that can be managed by the usual care team and that which needs specialist palliative care referral. And it is also, in the cancer version at least, been shown to reduce patient unmet need by its introduction. And as I say, it has been adapted and validated for people with ILD. So I'll talk about the tool itself in a minute, but just to say it was adapted from the cancer version, from using ILD literature, using focus groups of patients, carers, and clinicians, and an expert consensus group with academics, clinicians, patients, and caregivers, and a workshop more broadly of clinicians from around the country. And its aim is to be used in everyday practice. So here we have the one-page tool on the right, and I'll go through this in a little bit more detail, but basically it is to be used as a clinical guide. It is not a questionnaire to read out. So the clinician starts the consultation exactly as they would, asking the patient how they are, and then only when that initial conversation has been completed would then the clinician say, now I'm just checking that we've covered all the issues that we need to talk about. Oh yes, we've talked about this, we've talked about this. Now here's something we haven't. How are you feeling about your family or your ability to cope with things at home, or whatever it is that this tool prompts the person to then ask about? The clinician then makes the decision about the level of concern, and it can either be, I have no concerns in this area, I've got some that are potential ones, I've got significant concerns, and then it's matched to an action taken. Either I can manage this myself, no, I need to refer to someone else in my team, perhaps a physiotherapist, or actually this patient needs to be referred to specialist palliative care. And at the bottom of the form, there's a yellow section that can be used as a referral form. And then the whole form can be used. The person to whom you are referring can see a profile of concerns to identify which are the most pressing. So just to go through it in a bit more detail. So right at the top, there is what we've called a red flag section. And it's, if present, kind of raises the awareness that this is a patient who is very likely to have unmet palliative care need. So clinical evidence of right heart failure, deteriorating performance status, repeated unscheduled contact with hospitals as a marker that all is not well with this patient, and also failure to attend clinic. Again, these things should be a marker to think there is something not going well with this patient. Then there's a section about patient well-being, and it covers physical symptoms, psychological symptoms, issues about daily living activities, spiritual, existential, work, financial, legal, health beliefs, cultural and social factors that might make care delivery complicated. And these are all part of that really good holistic care for the individual patient. And there's also a section about information. The important, think of the family caregivers alongside the patient, something that is often forgotten. Now, this may be a cultural difference. I don't know. In the UK, caregivers tend to be parked in the corner of the consultation room and ignored. I think that is not the case so much in India. From my understanding, the family caregivers are much more part of the clinical consultation. So even more important to assess, are they able to care for this patient? And so you can see again the issues to address. Are they distressed about symptoms, difficulty providing physical care, coping with psychological symptoms, etc., etc. So it provides a systematic review of what is going on with the patient and the caregiver. There are challenges, and in our workshops we heard from the respiratory teams, and they said we're not very good at either identifying or actually managing symptoms. The barn door ones, when it's starting to affect activities of daily living, we'll pick it up, but in the early stages we tend to just kind of ignore it. So training clinicians how to assess and manage symptoms, and also the communication skills to get into the more challenging and difficult situations, and also to signpost to other sources of support. And there may need to be some hard thinking about the service provision. You may need to think about reconfiguring how we do things. You may need to think about the skill mix, clinical pathways, about having MDTs with palliative care inputs, that's multidisciplinary teams. May need to change priorities, legitimizing that little bit of extra time up front. To complete one of these tools takes on average about 20 minutes, but that time up front and then putting in plans to address these unmet needs can save time later. So in conclusion, most people with interstitial lung disease have palliative care needs. All interstitial lung disease clinicians should be able to provide basic symptom management, to identify and triage other palliative care problems, including psychospiritual issues. We need to involve the family caregivers. Firstly, they're a source of valuable information. They're living with this person often, or at least having very close contact, and they may have care needs in their own right. The needs assessment tool for progressive disease and interstitial lung disease is valid and reliable to help identify and triage unmet need. However, training is needed. They need respiratory clinicians, and I suspect primary care clinicians as well need training to assess symptoms at an earlier stage, and the communication skills to manage triage and also to address issues in the clinic. The focus, therefore, must be on the disease and its effects. So I leave you with a challenge of the day. The incorrect perception that palliative care is synonymous with end-of-life care, with no role earlier in ILD, has created a culture of neglect. So that is the challenge, and thank you for listening. The NAT-PD ILD is available to download from our website, and I have put the link there in the slide. So thank you very much.
Thank you so much, Dr.
Hello,
Miriam,
and thank you for the opportunity
for a very
to talk.
crisp presentation. Our next speaker is Dr. Sujit Rajan.
Sorry to interrupt. We didn't have any networking issues, ma'am, from our side.
No.
But the audio was not clear, but otherwise it's okay.
Yeah, audio
so,
is, I think that's the recording, is it?
Yeah, so just give me a second before the next audio.
He is a consultant chest physician in Vatia Hospital, Mumbai, and his interest is in interstitial lung disease. And he will be talking on palliative joint clinic, respiratory and palliative joint clinics need for the future. So over to you, Dr. Sujit.
Good day, everyone, and thank you for inviting me to this session at the IAPCON meeting. And I would have loved to be physically present at an offline conference, but this is the best way we can do it. And I'm sure shortly we'll have more offline meetings. So the talk today is on respiratory palliative joint clinics. And this is a topic that is very close to me, and I think something that we definitely need in the future. We are dealing with a lot of patients in respiratory medicine. And to give you a little bit of a trajectory of a respiratory physician, when you start, your focus is on building a clinical practice. And success is often defined by numbers that see you, waitlist and bed occupancy in the hospital that you work at. And this has been a very, I would say, immature or evolving way of defining success in clinical practice. And I guess it happens that many of us at our age have gone through this phase where building a clinical practice has solely, the success of that has solely been defined on this. Once you struggle a bit and build it, you have good numbers and you have very long wait lists and excellent bed occupancy. But what happens with that is actually diminishing time with the patient and reducing patient satisfaction. And that's something you definitely don't want to see. And the latter 2 points are important because it's something that you don't realize, because when you're focusing on line 1, the focus on line 2 and line 3 gets brushed aside. And when you end, you have good numbers, you have long wait lists, excellent bed occupancy, but not just no time for the patient, but you have no time for yourself as well. And that's how I've seen the trajectory of a lot of, in inverted commas, successful respiratory physicians. Reduced patient satisfaction is one thing, and reduced joy in life is another thing. And so we have to focus on both these issues moving forward. How do you start and how do you end well? And this is a prelude to really the joint clinic, is you need to figure this out on your own. I mean, there's often not a mentor who will teach it, because there are almost, you can probably count the joint clinics, respiratory palliative, not on the fingers of one hand in India. So you need to figure this out on your own. It's your practice, it's your patient's life and your life. And I'm sure there are a lot of palliative care physicians attending in, but I wish there were a lot of respiratory physicians also attending this, because that's the primary audience that I would like to drive some messages to. Be reasonable, not struggle, and value and respect both your time and the patient's time. I dwell on it actually when I come to this point of why do patients come for a second opinion? And why do they come for a second opinion? To me, for instance, from another competent respiratory physician. And I've always thought about this because I have outstandingly competent colleagues, and still the occasional patient comes in. And when you actually look at what is happening, you realize that there has been an inability to deliver in these 4 aspects. Inability to deliver adequate time to patients' concerns and questions. There's been an inability to communicate effectively. There's been an inability to understand and treat chronic breathlessness syndrome and understand and probe social and financial issues. All this has culminated in the patient actually coming for a second opinion, and not really anything to do with the disease per se. And that's very interesting, actually. And when you dwell on this, you realize that when patients have these issues, why do they come to a doctor in the first place? And there was a study from Yale that looked at why patients wanted to meet, or what they wanted from their physician. And they rated these as a doctor whom they could trust, a doctor who's competent, and a doctor who puts the patient's priorities before anything else when making a management plan. Sadly, two of these are often not taught in medical school. We are taught competency, for sure, but the other 2 points sort of get left behind unless you see them being drilled and ingrained into you more than often. That's where the palliative care physician enters, actually. And they wouldn't often have to enter if these things were ingrained, but for lack of time, it is often impossible for some busy respiratory physicians to actually have that listening capability, even if they want to, focus on what the patient wants, and actually have the time. And that's where the palliative care physician really plays. And the time decentralization from the respiratory physician's practice is amazing. And then there's this huge trust building in a team, and that is more than one person looking after the patient, both in terms of cure, care, and trying to limit patient disability and suffering. So there's a huge trust building when the palliative care physician enters. A joint clinic, I must confess, also allows everyone to be on the same page. And this is very important. So you don't want different messages coming in from one physician and another message coming in from someone else. It markedly improves the patient. Often I have to decide what they want to do is a big impediment to good quality care. So how do you build trust and sense patterns? So this a whole article and detail on what palliative care and respiratory medicine jointly managed is all about. But I will give you some broad guidelines or probably thoughts to dwell on. How do you build trust? First, you need to change mindset. You have to change mindset on this. And if you don't change mindset, nothing is going to change in a successful, in inverted commas, practice. And how does a joint clinic build better trust? and sends patient priorities, because one person in that joint clinic is seeing the patient with another set of eyes. Not some amazing qualification here, but just seeing the patient with a different set of eyes. So we need to change goalposts from how many patients do we see every day, how much do we earn, and how many patients are admitted under our care. These are ballpark figures for any corporate hospital, I can tell you. And these goalposts need to change, and they need to change soon with increasing privatization of healthcare in our country. And Charles Goodhart's law really contradicted this whole view so beautifully. He said, when a measure becomes a target, it ceases to be a good measure. And I cannot agree with this more when it comes to private healthcare and private hospitals' issues on healthcare, more patients, more bed occupancy. It cannot become a good measure of health. But next question would be, are measures important at all? Drucker said, if you can't pain and the issues in intensive care, invasive ventilation, renal replacement therapy and dialysis, escalating inotropes, antibiotics, high costs, drug side effects, mental stress, and just the dependency. Who is measuring this? I haven't seen anyone measure this in a hurry in any private healthcare setting, not in a hurry at least. So those goalposts need to change. In a joint clinic, you would look at how many patients leave that clinic satisfied and score it, measure it. How many patients with ILD and COPD are suffering less today? When you measure it, you can improve it. And how many patients actually leave a hospital satisfied with the care they received while being hospitalized? When you do those measures, some horrible figures can sometimes stare at your face, and then you know what you need to improve. Then you've measured it, as Peter Drucker said, and it applies to clinical medicine as much as it applies to management. So to conclude, you cannot manage respiratory disease without being either trained or associated with a palliative care team. And I definitely agree with this point. Chronic respiratory disease, you cannot manage well without this. Point two, wealth matters, but is very often not correlated with better care. So we are not discounting wealth, but it's not significantly different when it comes to quality of death in low, middle, and high income countries. Doesn't correlate with better care. Measuring patient satisfaction and quality of life and death are extremely important endpoints in overall healthcare policy. And that's why we need this at a national level. And conferences like this help to take that message forward much more strongly. And finally, I do strongly believe the joint respiratory palliative care clinics will be the future of chronic respiratory disease management. Thank you very much.
Thank you very much, Dr. Sujit Rajan. After a wonderful presentation, I think you have expressed your views in a very simplified ways, and also try to address what are the problems a respiratory physician generally have while dealing with these patients with interstitial lung disease. And particularly, time is a very important asset that is very important in communicating with these patients. And this is a very wonderful concept of joint clinics in which these parts could be addressed. With this, I would like to invite our next speaker, Dr. Rajam Iyer. Slides, please. Thank you. She is currently the consultant pulmonologist and palliative care physician at the Bhatia Hospital, ED Hinduja Hospitals, Mumbai. She has been there in pulmonology since '95 with please slide, please.
Okay.
And she's practicing palliative care since 2017. Her area of interest is palliative care in non-malignant conditions. She has received the prestigious Har Gobind Award in 2002 and Diploma in Palliative Medicine in 2020. She has multiple and important publications under her name. So I invite her for her talk.
A very warm welcome to all of you. It gives me great pleasure to be a participant in the Indian Association of Palliative Care Conference. I must say this is my first time here talking to all of you. In my journey of being a palliative care physician along with the pulmonology, in the past 4 years, I've actually got to learn a lot of things, not just about treatment and treating patients well, but also have made lots of lovely friends in the palliative care circle. And it really gives me great joy to be here this evening. Before at the outset, I would really like to therefore thank the organizing committee and Dr. Anjum Jod for giving me this opportunity. And without the support and constant encouragement of Dr. Sujit Rajan and Dr. Sunita Daniel, I wouldn't have been able to present this this evening. So you have heard Dr. Miriam and Dr. Sujit. And today what we are going to present to you is what difference we have made to patients with interstitial lung disease. To start with, I would just like to tell you what is interstitial lung disease. Now, it's a very broad name given to a condition which actually causes fibrosis of the interstitium. It is a chronic fibrotic illness of the lung. And also you must remember that there are many causes, for example, like connective tissue, radiation, drugs, certain allergic situations, for example, pigeon dust, etc., that can be a few causes of pulmonary interstitial fibrosis. Some form of pulmonary fibrosis is very aggressive and it's called as the fibrotic variant of interstitial lung. These can be compared to certain types of cancers because their survival is somewhere between 2.5 to 5 years. What we really need to understand is medically, this condition is progressive, is incurable, and eventually the patient reaches a stage of being a respiratory cripple. To add to this, the pandemic also has led us to challenging situations of post-COVID interstitial lung disease, only complicating the life of the treating pulmonologist. This condition is extremely distressing, not just for the patient, but for the caregivers as well as for the physicians. So introducing palliative care as an integration with pulmonology, especially for conditions like interstitial lung disease and chronic obstructive pulmonary lung disease, is a win-win for everybody. And that is unfortunately lacking in most centers. And I have been lucky to be able to do this study along with Sujit Rajan and all his referred patients. So this is another thing that I just wanted to highlight to you, that this is the interstitium is the part which is between the alveoli, which is the respiratory unit which takes part in respiration, and the capillaries. So if you see, this is where the oxygen comes from in the alveoli and the external atmospheric air. It passes on to the blood vessel through the interstitium. So interstitium is the sieve, and this is what is affected in interstitial lung disease. So the common distressing symptoms are dry hacking, sometimes persistent cough, progressive breathlessness till the patient is actually bed-bound and housebound, increased level of dependence and loss of role because of his breathlessness, and this patient eventually gets on to have oxygen requirement. The treatment that we have so far is, of course, immunomodulants, antifibrotics, as most of you have heard during COVID, which is pirfenidone and nintedanib, are the two medications which delay the progress of fibrosis but does not reverse the fibrosis that has already happened. Steroids have a main role when there is acute inflammation, what we describe as ground glass opacities, which is seen on the CT scan. Antibiotics are recommended as infection. Oxygen to be given when the oxygen saturation is below 88 to maintain a level between 88 and 92. We must advise the patient not to take oxygen unnecessarily. As you all know, it can also cause a nascent free radical damage to the lung. And of course, the biggest arm for good holistic treatment or support for interstitial lung disease patients is palliative care. So moving on to tell you what the burden is in ILD, there are multiple papers published about the unmet needs of these patients, right from the delay in diagnosis and then ending up with distressing symptoms. There's also a lot of distress and anguish for the caregivers because of lack of information, lack of time, lack of preparedness of what to do when their loved ones are so breathless or can get acutely breathless, what to do in an emergency. Unfortunately, as all of you will agree with me, that non-cancer conditions are not perceived as life-limiting. When you give a diagnosis of cancer, immediately the patient starts thinking of how much time he has. Non-cancer diagnosis is not perceived as life-limiting, and plus the pulmonologists who have seen so many patients of interstitial lung disease do not share this responsibility of foreseeing and foretelling the trajectory of the illness. Hence, patients end up suffering a very high symptom burden for a prolonged period of time with very poor quality of life. And since goals of care are not discussed and documented, end of life becomes a challenge, where the futility of aggressive intensive care in such patients with fibrotic lungs is extremely high. And therefore, it's important for us to realize the burden of treating interstitial lung disease cannot be borne alone by the treating pulmonologist. And we have seen in our experience that it really makes help to have a shared decision as a team between the pulmonologist, the palliative care physician, the patient, and the family in the center being focus of our care. So what we do is that first the pulmonologist evaluates the patient and he refers to palliative care on a need-based system. When I see the patient, I interview the patient and the caregiver. I also rope in the pulmonologist towards the end of the meeting if there is any specific area of concern. Followed by this, the significance of having the patient to have a general physician, and then we extended family. If the son or daughter is abroad, we rope in them by Zoom. And that's what the pandemic has taught us, that the world is now a small place. We speak to all the family members at the same time. Then I keep in touch with the patient's family, depending on what their convenience is, either between phone calls or WhatsApp messages or emails. And then slowly, as the rapport is built, we address the distressing symptoms, educate the family, give time for the caregivers to prepare, and also teach the family physician how to deal with planning of end of life and how to deal with any emergencies. So the referral criteria, as I said, was need-based. If the patient reports to the pulmonologist about distressing symptoms, that is one indication to send to me, or strong psychosocial family issues where the patient is not able to cope, or if the patient is a good candidate or in the window period for a transplant, then we really counsel the patient about all that can happen, because the patient might become an interstitial lung disease patient and followed by a transplant patient. So it's important to offer the family and the patient that support during the decision of going in for a lung transplant. Or if the patient is suddenly admitted with an acute exacerbation or there's a rapid decline in the patient's health, these are the indications for their patients to be referred to me. So what we did and what we are going to present to you is patients whom I have seen over the past 3 years. We actually sent out a Google form of the FamCare survey to the caregivers of these patients. We sent it to about 54 patients and we had a response for 32 patients. Now, what is a FamCare survey is that it basically has grading from very satisfied, satisfied, dissatisfied, very dissatisfied, and so these are the five numbers that patients, family caregivers had to mark, and the one on the left are the 20 questions that we asked the patient. So, for example, whether the patient's pain relief was addressed, whether there was a response from health professionals, whether how helpful the doctor and the team was when they were in need. So this is the FamCare scale that we adopted. And from the results, the respondents, we wanted to share with you that about 56% were female and 44% were male. These are the demographics, of which the age of the caregivers were mainly between 41 to 59, followed by under 40 and followed by more than 60. So it was a middle 41 to 59, which form the bulk of people who gave the caregiving. Most of these caregivers were married, and also most of these caregivers were employed, which means that we really did see that typical features of people who are in their 40s and 50s, who are working full time, who are married, and usually the women, as we see very often, is the common gender to be caregivers, especially family caregivers. So in this slide, we just wanted to show that the daughters as well as the sons, the children, are the ones who looked after these patients of interstitial lung disease. So obviously remember that these are the bulk of people who are relatively young, have a young family, who also have a full-time job. So it can be a multi-juggling problem for them to also look after patients who are going to be progressively declining in their health. When you talk of the sex of the patient, majority of our patients were male. And also, what is important here is we asked them the response in the global survey about whether patients were referred to physiotherapy. And as you all know, pulmonary rehabilitation is a big chunk of patients with breathing problems, especially if you all will already know about the breathing, thinking, functioning model. And the functioning model is what is focused by respiratory physiotherapists by offering respiratory pulmonary rehab. And it was good to see that we did quite well. By almost 77% of our patients were referred, and maybe the 23% who weren't referred could either be due to the fact that patient was too advanced in his illness, or was not technologically possible for him to do an online, or also the patient probably found it expensive, so therefore probably did not follow up with physiotherapy. The other thing which was important for us to highlight is the fact that we did use low dose, safe, immediate release morphine safely and effectively in almost 81% of our patients to improve the quality of life. And 81% of patients were prescribed that, and usually we have not exceeded the dose of 10 to 12 milligrams. This is from the data that we have stored from our prescribing patterns. The other very encouraging thing that came out of this survey is that 44% of patients had no hospital admissions after integration of palliative care, which means that the goals of care, the discussions, and the difficult conversations were had with patients, and patients were supported well at home with the help of the family physician or their help, skilled help at home. And it is important to realize that only 3% of people had more than 5 admissions, but almost 44% of patients had no admissions following palliative care, which means most of their concerns, anxiety, fears were addressed, and they were convinced that they should stay at home and not go in for aggressive, futile medical treatment. And the other important thing that came out of this was, out of our 32 respondent patients, 26 patients were dead at the time of the survey. And we actually integrated palliative care with the curative treatment almost 8.5 months before death. And this gave us a good time to achieve a rapport with the patient. Patient and the family had a lot of time to analyze and process the information. So we did have time to go back and forth about how to help these patients and achieve a good quality of life till death. So we did do the discussion. Yes, we had some patients who did come in very late, and we also had some patients who did get hospitalized. But still, even in the intensive care, we did manage to offer good symptom control and avoid unnecessary aggressive treatment. So amongst the questions for the FAM care, these were the questions that we specifically said, as I told you, from very dissatisfied to very satisfied. And in all the parameters, we did quite well, because the mean was almost above 4 in all cases, with a standard deviation as seen on the slide. So just to share with you what our patients told about us, and this is very heartwarming to see that palliative care can make such a big difference to a chronic progressive pulmonary condition, which otherwise people suffered with high symptom burden at the end of life and died in agony, or died in agony on the ventilator. So I think there's a lot of work to be done. And we really need to raise the awareness of how much a difference palliative care can do in non-cancer conditions, in advanced chronic respiratory diseases. And that is where I really want to focus in the next few years, so that we can integrate the care in respiratory medicine and make it a better experience for our patients and caregivers. Thank you.
Thank you, Dr. Azam, for a very you are very true that it's the most important point is that in non-malignant condition it is not perceived as a life-threatening disease. That is the only reason so why the symptom burden becomes very high at end of life. So a shared decision making should be there among the pulmonologist and the palliative care team, family, and the patients. So now session, I think there was one question from Dr. Biju Raghavan. So I think. So I have one question here. Any trials done in India to Rajan? Any trials done in India for use of morphine in breathlessness? Except
no, we don't. So sorry, madam. We haven't done an organized randomized control trial. No, I'm also very new in palliative care, and like I said, this is my initial few years of convincing my fellow colleagues to refer to palliative care, and I'm slowly, learning the ropes. So yes, it is very much needed. But I mean, I'm sure you're also aware of the abundance of literature of, by Dr. Miriam Johnson, by David Carrow on all the people interested, as well as with respiratory physicians across India.
Okay, and any other evidence you have before starting this trial?
So there are many randomized control trials available. So I mean, which has very clearly shown how effective it is for low dose morphine to be used safe and effectively to improve quality of life of patients, because it clearly decreases the sensation of breathlessness, and patients are able to do more even with their limited capacity of.
Yes, ma'am, please.
Yeah. So, hello, I'm Dr. Ashwin from SMS Medical College. And I just wanted to share with you that although, like ma'am is saying, we are not part of any randomized control trial for prescribing low dose morphine, but we have done it as a thesis, in fact. So we find that 2.5 milligram low dose or a 25% increment in those who are already on morphine substantially reduces the sense of breathlessness in patients. Although I agree that the randomized practice, we are morphine.
Miriam wants to add, and she is actually the. Over to you, Doctor.
A really good question. The literature quite as clear. Somebody believes, certainly some patients respond very well to oral morphine. Was such a as we would like, and we think this is partly because sometimes the patient of those who modified MRC before, this is something you would be considering because there is it. So this is for great business. But as I say, that there's the latest trial is the one from Daisy Janssen's group in the showed an improvement in quality of life measured by the CAT. Benefit. We are still the particular who would benefit, and it is are very breathless. That we're understanding is that actually variation in breathlessness isn't quite as fluctuating during the day as we thought. Actually, using a sustained release from the immediate setup, good idea, simply because it takes away some of that. You're treating the psychological breathlessness, pharmacological perception one. And I think there is so much of the emotion, affect, and the person's own personal response to breathlessness, the placebo control, because it's really, really hard to divide that I'm doing something that is going to help belief from actual something which gives an additional belief. So I would just say, yes, I'm there and we're doing the clinical trials with more placebo, but I don't think it's quite as straightforward. I think there are a subgroup of people who benefit, but we're not quite as good as we would like in identifying who they are. But they do seem to be the people who are most breathless. And for me, the mainstay of breath management is the non-pharmacological. All of them should be getting pacing, prioritizing, rehabilitation, breathing training, cool air, if you can, across the face, if you can persuade people to do it. I know that there are some concerns, particularly in hotter countries, that that's not necessarily seen as they want to do, but these sorts of things I think are a must. And having done medical practice most of my life, I know that as doctors we can really struggle with something that's not a prescription. And if we really support our physiotherapists and our nursing colleagues and our occupational therapists, saying to the patient, these are really important things they are telling you, that we back them up and we act as that member of the multidisciplinary team. Even if we're not writing a prescription, we can really, really help patients. Sorry, that was a bit of a speech. I didn't mean to go on quite so long. I do apologize.
Thank you. Thank you. There is one more question. It is for Dr. Mariam, who can use it, that need assessment tool, and how far it is validated in India?
So that's another fabulous question. It's great coming to these meetings. So firstly, we're very happy for people to download it on the website, and I'd be very interested to hear what people think about its use. I do emphasize it's not a list of questions to read out. It is a prompt. It's a guide. Have I remembered to talk about this? The second page does have some suggestions of how to get that works in your own situation, because it's not validated in India. It's validated in the UK setting. However, it is the only one that has any psychometric validation. So we would love to do that. I suspect the same implementation problems will in that it can't just be, here's your tool, use it. Please make friends with your palliative care team to work together so you have some support. Please, the respiratory people really do need to, again, have a little bit of assess those symptoms up front rather than waiting until they're so bad they're affecting activities of daily living. And also just a little bit of support in learning how to have those difficult conversations and learning how to signpost so that you're not getting into a big in-depth conversation if you don't have time to do it, but there are skills to be able to highlight, acknowledge, and signpost to someone else who can help. Otherwise, if you think it's going to get you into a big half-an-hour deep conversation and you don't have time for it, as clinicians, we don't go there at all. So it's learning some of these skills to manage that assessment within the time frame that you've got, supported by other people who can help with that teaching. So it can't just be picked up and then taken into clinic and off you go. It needs a little bit of thought about how you're going to put that into practice. I'd love to hear people's experience of using it, feedback, and if anybody was interested in helping validate it in the Indian setting, then we'd love to hear from you.
Thank you. So next question is to Dr. Sujit. What are the barriers in organizing a joint palliative care and ILD clinic among the professionals and the patients and the families?
So Sumita, there's not much of a barrier if one wants to do it. The barrier is usually from the hospital administration to actually have palliative care physicians even appointed in private medical care. We see that as a single most biggest barrier right now. And so I have to get to the other hospital I work at to actually ask for permission every time I need a referral to say Rajam to come to the other hospital. I don't think there is perception about how care improves when a palliative care physician is on board. And that only happens when you start off, you make a start, and then I think the body language of the resident doctors, the nurses in that hospital, and your professional colleagues, everything changes. So you got to start. You have to make that start. If you don't make that start, nothing changes in a hurry. But when you make that start, the satisfaction it brings you is nothing short of amazing.
Yeah, thank you so much.
Okay, I think, thank you very much, Dr. Sujit. I think that's, we've got time only for that much. I think we've crossed the time really. So I'd like to thank the chairpersons, Dr. Ankit, Dr. Sumita, and the excellent faculty, Professor Mariam Johnson, Dr. Sujit, and Dr. Rajamaya for the excellent session. Thank you very much. Bye.
Thank you.